Good morning, remote attendees. Brian Alston doing a sound check. Can you hear me? Excellent. Thank you very much. The meeting will be starting in a few minutes. Thank you.
Debbie, I'm going to start. Good morning. We're going to call the Finance Committee of the Cook County Health and Hospital System to order. Will the Secretary please call the roll?
Here. Director Harrington is absent. Director Lowry is absent. Director Robinson.
Present.
Chair Ryder.
Ryder is here.
And for the record, Board Chair Garza is also in attendance.
Do we have any members of the committee or other board members online?
We do not.
Okay, all right. The next regular meeting of the Finance Committee is scheduled for Thursday, January 8th at 10 a.m. Debbie, is there anyone registered to provide in-person or virtual oral testimony or submitted written testimony?
We did not receive any registrations nor any written testimony submitted.
All right, I am going to just real quick see if there's anybody in the gallery who's looking to provide testimony who hasn't registered. There's a gentleman who just walked in. I didn't know. Are you looking to provide public comment? Okay. All right.
He only has 3 minutes, right?
What's that?
He only has 3 minutes, right?
Yeah. Sir, you only have 3 minutes if you want to take them. All right. First item on the agenda is the November 13, 2025 Finance Committee meeting minutes. These are approved at the November board meeting but are being presented for the committee's review and discussion if necessary. Are there any corrections needed to be made to the minutes? Any corrections? Any corrections? Is there a motion to accept item 3A, the November 13, 2025 Finance Committee meeting minutes?
So moved.
Motion's been made. Is there a second? Second. Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right. Next item on the agenda is items under the Chief Procurement Officer. Approaching the hot seat is Charles Jones, our Chief Procurement Officer. Charles, we have a pretty big list of items today. So it's 130. Oh no, it's 13. 13.
Yeah, actually, so not. Hey, good morning, Charles Jones, Chief Procurement Officer for the Health System. So, request.
Fortunately, none of them are staffing contracts, so those always take a long time.
Yeah, the ones that come in later. Request. There was request number 2 will be withdrawn. So therefore, we have 12 before you today. Of those 12, 11 require responsive letters from the Office of Contract Compliance. We have 10 back and 1 in process.
All right, let's roll. First item is Health Plan Services, being presented by Aaron Galiner, Chief Administrative Officer, Health Plan Services.
Thank you, Chair. Good morning, directors. The first item is with vendor Zapongo, which is an extension of our current food nutrition program. There's 3 components of this scope, which include emergency meals for those who have an urgent need among our membership, medically tailored meals for certain conditions, and then broader access to dietitians as a benefit under our program.
Any questions for Aaron? Aaron, thank you. All right. Next item is request number 2, being presented by Dr. Nutter.
Request 2 is withdrawn.
Oh, that's right. You said it. Request 2 is withdrawn. Request 3 through 4, clinical. Dr. Lauren Smith, our Chief Medical Officer.
Good morning, everyone.
Morning.
So the first is an extend and increase contract with Dr. Murray Pelta, who works with our OBGYN department and within family planning. It is a contract not to exceed $315,000 for a 12-month period ending October 23rd, 2026.
Does anyone have any questions? All right. Go ahead and to the next one.
Okay, and our next is an execute contract with Abbott Laboratories. This is a GPO for products and supplies that are used in our angio-cath lab, so for cardiology patients, not to exceed the amount of $210,000 for a 36-month period through November 30th, 2028.
All right. Any other questions? Hearing none, thank you. And we're going to move now to request number 5, health information systems, being presented by our Chief Information Officer, Angela O'Banion.
Good morning. The request before you is to execute a contract for $6.45 million for one of our MeBe-Weebies, Clarity Partners. Clarity, this is for resources that were originally under the Cerner Oracle contract, and as Cerner and Oracle continue to align their practices and policies, they ask that these resources be moved from under the Oracle contract, which we have done, and we decided to just do the contract directly with the MeBe-Weebie. And the reason it's sole source is because the people on this contract have been working with Cook County Health as existing partners for well over 10 years, most of it.
All right. Any questions for Angela? Thank you, Angela. Next, we're going to go to request number 6 through 12, being presented by Operations Development, being presented by Craig Williams, our Executive Chief Operating Officer. Before we dive into these, Craig, when we get to the staffing contracts, I want to pause and then take out of order the informational report that you and Wynn provides. That way you guys can give all the background and context to then talk about the staffing contracts.
You know what, I think you may be in my head, because I was thinking this morning, it'd be so much better if I presented those contracts after we presented the data on it.
Look at this. Look at this. It's amazing.
Great minds think alike.
So Wynn, be ready for that. All right.
All right.
Yeah, and just for the record, Director Harrington and Commissioner Lowry have joined the chat. Go ahead.
Okay, the first I have is Biolytical Laboratories. It's an increased contract for $90,000. Same contract period ending 8/31/26. And this is to provide HIV antibody testing to increase our overall testing across our priority population and help to improve early diagnosis and reduce the number of undiagnosed individuals living with HIV. The next one is Allied Waste, DBA Republic Services Chicago. It's an extended contract with no fiscal impact, 12-month contract period, 12/1/25 to 11/30/26. It may provide our non-hazardous waste removal services throughout CCH. this is the first of the staffing
Yeah,
contract.
so let's, on request number 8, Charles, you don't have to completely leave, but maybe go off to the side there. Give yourself a live mic.
I did need you.
Yeah.
Hi, thank you.
Debbie's gonna skip around now. We're gonna go to their presentation, that their,
Perfect, right here. Thank you.
we're gonna do the whole thing right now, and come back to the rest of the contract.
So we will go over the current state of hiring. For the past 12 months, we've made significant progress in hiring. Our offer activities remain strong. Year to date, we have made 2,020 offers. I told you. Of those, 1,421 are accepted, which provides us with a 73% acceptance rate. We filled 1,332 positions, up 196 positions year over year. Of those, 944 were external new hires and 388 were internal. Separations have shown a consistent decline. We've seen a downward trend in retirement, and resignations and discharges remain somewhat flat. Net hiring efforts continue to show positive momentum. We have net hires up 464 this year, so that's 170 hires more than the year before, so that's about a 58% increase year over year. Next slide.
Great, thank you. This is our current state of agency use, a slide that everyone's familiar with. For the month of October, we had another reduction in our overall agency use, down from 806 in September down to 762 in October. That puts us at about 10% of our workforce on a given day is agency contracted staff. That's down from 1371 in September of last year, and almost 19% of our daily staff being agency. Next slide.
Craig, if I could, before you go on, sometimes I need to be spoken to as though I'm in 3rd grade. This is one of those times. So I just want to have clarity. From September of 2024 through the present, what's our overall percentage of reduction for agency use? Is it 30%, 31%? Where are we?
I think it's 44%.
44, thank you.
Yeah.
Perfect.
That's a key figure for the next part of the presentation.
Okay, thank you.
And remember, the request that we originally had was for us to be under 20%, and the distinction was that we were getting hung up on was 20% in each category versus 20% system-wide. Now, it's easier to manage on a system-wide basis because you have to work your way through it all. And so many departments and so many people. You can always like zero in on a job title and, get upside down real quick because there's 3 people in that job title, and you're experiencing, 2 people transitioning one way or another to like retirement or just changing careers. But I think if you can't argue with going from 18% system-wide down to just over 10%.
Yeah, I would say that I think that this reduction shows our commitment to, right-sizing agency, not using agency to augment staffing where we actually don't have positions, which, something that we did in the past, and we've controlled that. I think you also see in the next slide is the places where we're using agency now are places where we have high vacancy rates, and as a result, there's recruitment challenges around those things. So it's a place, when Wynn says, see, I told you we made 2,000 offers, it was because of a discussion we had earlier around, man, we got to get more people hired, and so it's a lot of work. And ultimately, I think, in terms of like aligning with the union on what they want, and I know I'm not supposed to give my opinion here, but I think like we've done that, right? We are staffing where we need it with agency, and if we didn't, then it would be the burden would
I
actually.
mean, you have a high-level position in the organization. I think your opinion is
Okay.
useful to have.
The burden would actually go back onto the union members, because with high vacancy, if they're the only ones left standing and we can't augment staffing in any way, the workload's just gonna be too much for them, right?
It's
So
a balance,
I just feel like we're more aligned. We wanna hire those people, we don't wanna be paying premium labor.
And I think to Craig's point, we're very much more intentional about how we're using agencies. We had a call this morning where we go through every request, and as a committee, we decide, yes, we need this, and if we do, then we send to the next level, which is approval to HR. And then from there, we'll go, we're not just making the decision unilaterally at a level anymore.
what I've heard from unions that work in the healthcare space, which includes here, given that I do this, is that it's not the usage of agency in the workplace that's the issue. It's using agency to displace full-time workers, because everyone knows that there's a necessity based on the type of operation. You can't slow down production to deal with hiring more people in a large public safety net hospital. You have to be able to, jump in there when you're having problems with hiring trends and things like that. Well, no, I think we've done a good job of working towards alignment between ourselves and the folks who represent our employees.
This is just the same information broken out at the job code level, and so this is where you can see where, certain positions where we do have higher, just overall staff, like nursing, we have, a large number of positions in nursing, and so agency as a percentage of that is gonna be higher, but then some other places where, we need to, increase our recruitment, and I think we're doing a lot of work around the advanced step hiring, the advanced, accelerated hiring has been really helpful in some of our harder to, recruit positions.
When I know nursing is a key area of focus going into 26, do you want to talk a little bit about some of the things?
Yeah, so we've did AHP and for nursing, we're also doing some conversions that are happening, as we speak. So we work with NNOC to go through the conversion process to convert agency employees to, CCH. I believe we'll be going through CCH this month.
Yeah.
And then we've also talked about demobilizing agencies that come in here after a certain amount of time, right? So that's part of the agreement we have with NNOC. And then with accelerated hiring, we hope that opens the door to hire faster, to support the needs of the nursing department.
So I do want to say, nursing being mentioned and some of the position focus is not solely on, because there are many, but the main two things are the agency usage and how it reflects on the cultural stability of our organization. That's one. And then the second focus, why it was position focused, is because we were talking about agency spend, how much of our resources are being put towards agency. So there are two things, and I love that we've gotten absolute numbers in general down, but the breakdown specifically by position and role was more, for our resources being put. I love the work, and I think what feeds into this too is the work that you all are doing in the realm of team development and nurturing people once they're here. I think that will greatly impact our ability to engage, recruit, bring on and maintain our team. So yes, it's going in the right direction. I believe it looks like we definitely are headed in the right direction. I just want to put in that caveat. There are two things, mainly that we're talking about the spend, and that's why looking at the roles are in fact important, and appreciating and reflecting on what you've done and how we've gotten the absolute number of agency down. So now the opportunity to focus on the role is important because the spend per role impacts another realm of agency resources. Thank you.
That was my comment, actually. Interesting, you got the same thing. I don't see how we are making that spend become a part of how it impacts our budget, because it is a big piece. When I see 39.9% are nurses, that's a lot of money. And how do we actually help to make that come down? Which I know you have some great stuff. For those who were not here, the human resources did a fantastic job in showing us the roadmap of what they're going to do and how they're approaching it. So that's fantastic. And, again, we congratulated you then, and I'll congratulate you again, because it was fantastic. And I'm really happy about what I see where we're going. Commissioner Lowry, I don't think you had a chance I don't think you were present for that. I was not. But if you get a chance to look at what they're doing, fantastic job. They have the right motivation. Everything is just absolutely top notch. Thank you. Again, I ask questions, but I give the accolades when they are due, and you are most certainly due them, given what you presented to us. So again, congratulations and thank you.
We have a really good team.
This may come up, I mean, we could probably talk about this during Pam's report, but I do think that the agency reduction and our ability to adjust in the spend under our budget, we were able to buffer some of the headwinds that we had with some of the problems with Medicaid and the ACA. Am I right?
I don't think that's right.
Yeah. So it's getting the work that they are doing, that you're about how to plug it into the budget. It's actually gotten plugged into into adapting this year's budget and adjusting the spend. So we've seen the benefit of it, and I believe that those numbers then got baked into our the fiscal year that just started. These guys are meeting your expectations on that, is where I'm headed with it, Sam. So You're doing a good job. Continue. Oh, I had a quick question. On health information coder, I'm looking at because that's a newer category that we put in there. We're at 9%. How many, I'm not gonna spend a lot of time on this. How many health information coders do we have?
Before Curtis answers that, the 9% is what that
Oh, the
job
total
code
agency.
represents as a
Right,
total.
okay.
Yeah.
What is, 16? Okay, all right. All right, great, keep going. Or you have another question? Joe?
No, it's more an observation and a comment. I want to commend you, and the good thing is you've raised the bar. The bad thing is now the bar has been raised, so we expect you to continue doing good work. So you're off the hook for right now, but if there's a dip, I'm sure we will address it. Understood?
Yeah, I guess on that, I would also just add, I mean, obviously, I hate premium labor, and I would love to get all of it out of there. That's overtime and agency use. But the alternative in many cases actually would be turning patients away and turning volume away, right? And so, I think we are very rigorous, especially as we think about the budget process and around this process, around ensuring that the things we're bringing in are going to have a volume on the other side. So we had a discussion this morning about a business manager agency replacement came through. We had a long discussion about that. It's like, why do we need to approve a business manager? It ended up being a special case where someone was out on medical leave, and it probably made sense. But
Craig,
there's a lot of rigor on that.
I gotta tell you, when your expenditures on the lines that, you manage, which is a big part of the budget, when you're over budget on your expenditures, but you're outpacing that on revenue, and same thing with Aaron, I'm happy, right? Like when you break your budget because you have to spend more on expenditures to deal with the increase in revenue that you have, you're good.
Yeah, the challenge is we don't necessarily have that ability to do that though, right? So,
Yeah.
good new business, we sometimes have to turn away because we
Yeah,
don't have the
right.
Sorry, I'll get off my soapbox.
But that, I think, again, I think we all understand that we have to have an agency resource there. It's the crutch that you've been undoing these last 2 years that I think's been critical. It's not a way to displace or expand service lines without acknowledgement that, you know, you're staffing for that, because you're right, premium labor is good when you have to shift to it, but it's not a good fiduciary use of the money.
No, fiduciary and culturally. Yep, completely agree. Okay, next slide. I think it's locums. So this is our locum utilization. It's stayed pretty steady state. It's really providing, you know, direct vacancy support around physicians. Don't have many other comments on this slide unless folks have questions. All right, fine.
Good morning.
Frank, are you on?
Yeah, I'm here. Good morning. Happy to report continuing progress on our efforts to build a talented team of soft money funded staff at Cook County Health. As we've been reporting over the last several months, we continue to make progress bringing folks from Hectone to MEDEX and MEDEX to CCH. This slide provides kind of a snapshot of where we were at the end of November. In effect, 39% of the folks that had been shifted to MEDEX had been onboarded to CCH, with 3% more scheduled for onboarding sometime in December. I just had a meeting yesterday with HR, and we continue to make steady progress with the balance. All but 3 of the remaining positions, we've gotten RTHs approved. All but about 11, we've had the positions posted. Another 10 or so offers are in progress. We're still on track, we believe, to get 90% of these staff at MEDEX offers before the end of the calendar year, and onboarded sometime early in January. We're excited about this, getting this completed. And once we have it completed, we'll be able to step back and take stock of the large and talented team of professionals that we have to work with to build our grant-funded portfolio going forward. Happy to take any questions.
Any questions?
I'm just curious, because I can't remember, why is this process so long?
There are a lot of steps involved in recruiting. It starts with creating a position, and then kind of getting a PID, and then an RTH approved. And in the grant-funded world, there are kind of classic steps that a careful organization goes through to make sure there's adequate funding in-house. And the budget in the grant or contract calls for the specific person that we're proposing to recruit. And then once that it's gone through those steps, there are a bunch of downstream steps to post the position and then solicit the applications, review the applications, make the offers, etc. So it is a lengthy process. And it's made more difficult because of the macro environment. We're talking about roughly 20 grants and more than 100 people, and each grant has its own timelines and idiosyncrasies about when it got set up at Cook County Health. And the other wrinkle, the last several months has been some uncertainty in the federal funding environment. So many of these grants are, they have a time period when they start and they end, and we're always positioned. In general, we're positioned to get a renewal. And there was some uncertainty with some of the grants about the renewal, which led to some uncertainty and delay about, do we have the stable funding with which to, to basically authorize, to go ahead and, hire for this position. So that uncertainty has been resolved except for 3 RTHs, and I'm confident that by the end of this month, the remaining 3 will be resolved satisfactorily.
Yeah, we're talking about a total of 113 individuals, 66 of which are currently staffed through MedX. Where do they fit in the overall system? I mean, what types of people are they? These doctors, researchers, nurses? Do we have any idea of who we're talking about it as a group?
Yeah, incredibly diverse group. Each of the grants has very different needs. So we hire, folks who are, phlebotomists. We hire folks who are, clinical trial coordinators. We hire people who are skilled in research methods. It just depends on the grant and the scope of work and the staffing needs. One of the reasons, although I'm excited about getting this whole talented cohort over to CCH, is then we'll be in a position to more strategically, manage this talent, and not only to further CCH's mission, but also give these staff opportunities to grow. So right now they typically have been funded by a single grant. A few of them have been funded by multiple grants, but once we have the whole portfolio over here, we'll be able to take into account people's interests and skills and place them across various grants and proposals that allow them to grow and enhance mission impact for Cook County Health.
It would be more work, but it'd be interesting to see how these people have been integrated into the system and where they're working, what types of jobs they have, and if they were comparable to the jobs that they had prior to this.
Yeah, I think in another briefing, I'd love to give everybody an update on what does this group of talent look like, in terms of titles and the numbers, and how do we see managing them, for increasing value over the next few years.
I think that would be important. It'd be very helpful because we're talking about how we've impacted over 100 people's lives. And so some context would be helpful.
I agree.
Before we leave this, can I ask a question, Chair? Yes. So I guess I'm curious what we learned about this experience, given that it was an experience that we had to move to as a result of the event, and how that influences our evaluation of these types of situations going forward, so that it doesn't take an event for us to determine we can bring this in-house and do the work that we're confident we can do.
So I can speak to kind of the changes that we've made in partnership with the county team. Part of what Mark is talking about was the process whereby we open positions, these grant-funded temporary positions, and they have, in partnership with us, offered more latitude in terms of opening the positions at the notice of award. It used to be we had to have the money on hand to open the positions, so it would add a lot of lead time to try to open these positions. So it's something relatively newer that I think going forward was a learning, and and working with Mark, it's very rare that you get a notice and then the funding doesn't end up coming through, right? So kind of really paying attention to that, working with the county team as well. I think that was a learning in terms of process improvement. Mark, I don't know if you want to talk a little bit more about that process.
Yeah, there are a lot of valuable lessons, because what we've been doing is kind of transferring grants and people over time, but at the same time building and modernizing the operation at CCH, and there's interaction between the two as we've been transitioning people and grants over. our sense of kind of what we need to be successful has evolved. And so, we have a roadmap for, operational improvement, and that keeps evolving as we, continue to make progress. I think at a subsequent meeting, it would be good to kind of take a step back and reflect on all that we've learned over the last couple of years, and what the roadmap for the next 2 years looks like.
Thank you.
Is that it? Is that
I think
the end of the
that's it.
report?
I think we can go back to the.
Yeah. All right.
I will switch on my seat.
Unless anybody has any other questions. All right, thank you. Charles, you get your chair back.
So with that segue, which sets us up purposely for the next 4 contracts. So these next 4 contracts have historically been used to obtain agency personnel across multiple departments at CCH, including transportation lab, ambulatory services, and radiology. So many of the things you saw on those slides outside of nursing fall under these 4 contracts. In FY '25, the contracts that these are replacing, the annual value of those contracts was just under $74 million. What we're asking for moving forward is just under $47 million, so a reduction of $27 million over the next 12 months. And that represents a 37% dollar increase, which aligns with that 42% decrease that we've had in overall FTEs. If anyone wants to ask me why those numbers don't match exactly, I would say that I'd probably put some hedge in the numbers, just around the process, that sometimes we get some older invoices. I just want to make sure that we're not having to come back. I'm hoping not to spend the full contract value, but just in full disclosure, that's sort of how we built this analysis. So let me go into each contract. The first one is Amerigis Healthcare, which is Maxim Healthcare Services. It's an extended increased contract for $23,896,000 with a 12-month contract extension, 1/1/26 through 12/31/26. This contract is a 16% reduction from the last 12 months, going down from about $2.6 million a month down to about $2 million a month. The next one is Cross Country Staffing. It's an extended increased contract for $8,153,000. It's a 12-month contract period, 1/1/25 to 12/31/26. This request is a 60% reduction over the FY '25 spend, which was about $1.8 million a month, down to just under $750,000 a month. The next is Corsair. It's an extended increased contract for $7,165,000. 12-month contract period, 1/1/26 through 12/31/26. And this request represents a 30% reduction over the FY '25 contract value, from $941 down to about $650 a month. And the last one is AV Staffing Solutions, which is a more specialized contract that is targeted at replacement of radiology techs, most notably the higher modality imaging of CT, MRI, mammo, and PET CT, and that contract value is $6,048,630, and that's about a 30% reduction from the prior contract value. This is the only contract that's a 13-month contract, and we just did that to align with the endings of the other contracts that we had in place. Any questions on those before I move on to the last one I have?
Any other questions? All right, thanks. Go ahead, Greg.
One more. Aruba Neurosciences Innovation Institute is an execute contract for $7,704,179. 36-month contract, 1/1/26 to 12/31/28. So over the last 6 months, we've been working on an opportunity with another system in the Chicago market that would create relationships around our neurosciences service lines, specifically around stroke. And so the idea is that we would provide stroke services to these other hospitals, as well as some on-site rounding and clinics and support there. And in turn, we would likely see more stroke volume here at Stroger Hospital, which is incredibly So this contract is with a group of 3 physicians who are neurointensivists, neurointerventionalists, and they'll be providing services mostly at the outside contracts, but also will be augmenting some neurology staffing here at Cook County Health.
So in lay terms, what this would mean is people would get that service here as opposed to referring them out to another place.
What we hope to do is create more glue around the referral relationship. So what happens is if you're having a stroke, or you think you're having a stroke, you'll go to your nearest emergency departments. Many of those don't have 24/7 neurology coverage. And so through video and systems, we'll be able to connect with them, evaluate the patient, either say, that person's perfectly fine to be cared for in your institute, provide some guidance, and they stay there, or if they need probably more interventional services or neurosurgery, they transfer here. And so that, by creating that relationship, it ensures that that transfer is going to come to CCH as opposed to go to Rush or Northwestern or another.
Craig, a part of the more global agreement is putting in place transfer agreements in addition, right? So we'll have the team helping to keep appropriate patients at the partner facilities, but then we establish that transfer relationship so that we're getting the higher level needs here. That's further.
And I understand that. I'm trying to understand, is this somewhat revenue neutral in terms of spending this money?
I should say that. So I think the majority of this actual contract is going to be paid in fees back from this other system directly to us, plus any additional volume we see from the relationship.
It would be nice to see if that's in fact the case, because this is finance committee and we're looking at the money.
Yep. Right. It's almost 100% supported directly.
All right, any other questions? Thanks, Craig.
I'll go after, Director Green.
So I think in light, again, because I'm noticing, there needs to be a balance, and there are great things being done, so let's just say that, so nobody has to come behind me and say it, okay? But the reflecting on why we asked about roles, you see, what was presented today is a great example of why we asked about roles when it comes to finance and things like that, and it's important to look at. I'll put at the end, because I see I hear how we like to hear things. There are great things being done, and process improvement is just part of a well-managed organization. It's a whole book about it, So I think the importance of looking at roles and where the agency's been in, here, what was presented today, while needed, is a good example of why we need to kind of have a lens on both. Are we clear, or do I need to? Okay. And thank you.
If I could just add that great things are being done.
Sam?
The question I have, the telestroke is absolutely fantastic because it matters in seconds. We understand that completely. The question I have, the transfers that we're looking for, and no one think I'm cold when I ask this question because it's a legitimate finance question. Are these paying customers?
So the relationship is with systems geographically serves a different payer mix than what we serve. So some obviously will be uninsured, which is part of what everyone does, but we think we'll see a higher percentage of commercially insured patients as a result of this relationship.
So at the end of the day, this is about keeping the right people in the right place, right? The right patients, right? If they can stay at those community facilities, that's great. If they need a higher level of care, it unburdens our emergent care here, right? That can be treated out in the community. With that, and it saves time, right? So all of this at the end of the day is driving towards better outcomes, right? That's what we're trying to do, is create a
better quality of life.
Right. So
Ellie has her hand up.
Yeah, I
Ellie?
just want to echo what Dr. Makita said. It's not to create a referral or a referral pattern. It's so that we can more ably treat the outlying areas so they don't come to us in such an emergent fashion and create those healthier communities.
So you see the numbers to justify the statement that was just made? Because it's a great statement, but my question is it backed up quantitatively?
Yeah, the teams work through multiple pro formas. This makes sense both from a community standpoint and,
So what you, let me be a little clearer. So if you look at your historical records, you've seen X number of people coming from the outside with these conditions, and you said if we can treat them, we wouldn't see them here.
So for this specific, we know stroke volume at these different sites. And so that's specifically how we sort of built this. And right now, we're not a comprehensive stroke center, which means when someone calls 911 because they think they're having a stroke, they can't come here. And so this, we believe, will help us get to that. The only thing we're missing is endovascular volume to get that designation. And we believe this relationship will help us get to that, which would then get us into the EMS loop, which then, is more better for us overall, is what I would say.
And I would just say on this, we have to make sure that we're mindful of what the CMS rules, that this is not a line where we can make money.
That's why Ellie she's been heavily involved.
Yeah,
in
this is a service that we need to provide. So we just have to be mindful of how we view this. This is about getting the proper amount of care, and making sure that the costs align so that we can do it. Not so. This is not a money making line. Is that fair to?
And Greg, I appreciate you helping us to understand how it helps us move down the path. That's pretty important. Thank you.
Sure.
All right. Great. And I think, Donica, you look like you're ready to get up. Thank you for being patient. All right. Donica has one contract to present, and I put a whole bunch of stuff in between her and being able to do her report. So.
Thank you, Chair, and good morning, Directors. This is an execute contract with CCH for a lab supply and service. This is reagents, consumables, controls, rental service agreement for the immunoassay and COVID testing. The amount not to exceed $6,735,383. The contract period is 1/1/2026 through 12/31/2028. The vendor will provide reagents, supplies, placement and service for the microbiology testing performed at Stroger, Provident, and 12 clinic locations. This includes testing supplies for 18 separate instruments in those labs. The contract includes 2 one-year renewals, and this is a sole source because the vendor is the original equipment manufacturer of the equipment owned by CCH.
All right. Any questions for Donica? Hearing none, thank you. Charles, before we consider this, do you have anything else you'd like to add?
No, not for the contracts and procurements.
All right, thank you. Is there a motion to approve item 4A, contracts and procurement items containing request number 1 through 13, subject to completion of a review by contract compliance?
So moved. Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. Charles, you told me that report, that was gonna be shorter than normal. What happened?
Yeah, I thought so. It averaged over 4 minutes a contract. So,
All right.
thank you guys very much. And before I leave the table, Chair Wright, I publicly want to say that I'm enjoying the flow of your Christmas tie and your Christmas shoes.
Thank you. Thank you. Can't get up every day and entertain yourself. It's not worth it. All right, items under the Chief Financial Officer.
we first have a proposed resolution to open a new Cook County Health bank account at JP Morgan Chase Bank, and that's being presented by Pam, and it looks like, Scott.
That's right.
All right.
Good morning. Pam
Morning.
Casera, Chief Financial Officer. As many of you may have heard, this is my last finance committee. I'm departing at the end of the month.
Stole my thunder.
So I am passing the torch to Scott, who'll go through my reports today, but I wanted to, first of all, thank the board for their support and, let you know I'm leaving you in good hands. We've made a lot of progress over the last 4 years in finance and rev cycle, in all the areas related to, people. We've gotten some really strong people in place. Our processes are much improved, and even our technologies have improved. So I just wanted to thank you again and assure you that things will continue to run smoothly. And with that, I'll let Scott talk about the resolution to open up a new bank account.
All right, so, good morning, directors.
Good morning.
Yeah, so the resolution, in front of you is, to open, a second, bank account at Chase. We already have a bank account at Chase, but we need another one added so we can, track the 340B rebates that are coming back into the organization. So this account would be used exclusively for those rebates.
I have a question if I could.
Sure.
So first, I want to say, Pam, you've been just wonderful to work with. I wish you nothing but success, but I know, having gotten to know you, you will have success in whatever you do. But you truly have been just a joy to work with. So I just want to acknowledge that publicly, and we'll certainly find other ways to say that as well. As we work with Chase, and this is something that I really believe strongly in, I've had preliminary discussions with Madam President about it. I think they're a wonderful institution, but I think sometimes institutions like that need to be asked to do a bit more. And they've got a program, Morgan Health, which aims to improve quality care and access for its workforce as well as the general market where they're doing business. Just note Morgan Health. Let's have a conversation with them at some point and say, as our partner, we want to make sure that we're availing ourselves to all of the possible partnership opportunities which may exist for Cook County Health. Okay,
Sure.
thank
Take
you.
that.
Any other question on this item? All right. Is there a motion to approve item 5A, the proposed resolution to open a new Cook County Health bank account at JP Morgan Chase Bank?
So moved.
Motion is made. Is there a second? Motion is made and seconded. Any discussion? Hearing none, all those in favor signify by saying aye.
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 Opposed? You guys have it. I just want to go back for 1 second. Just to note for the record, we don't have to redo the motion because it's implicit in it because we didn't present it, but, request number 2 had been withdrawn, which we did not go over, so that is, request number 2 is not included within that motion. Before we move on, because I don't know if we're doing this today or if we're doing this at the board meeting.
I'll be at the board meeting.
Okay. You want to wait till then? Incredible shift in how we do our finances, how our finances are presented, the transparency around our finances, the predictability, the way we measure. I mean, we used to spend a lot of time on things in our old finance reports that, I don't know that really were as important as the things that we cover now, just things that were sort of space fillers that we received this report at the finance committee and at the board meeting that I think this is what the last person presented, so we're going to continue following this. In the way that the numbers have been presented, I think that there's, you've adjusted, you've shifted, we didn't have to ask for changes, you started presenting things in a different way. That's our engagement level, right? The commissioners, I know from attending meetings downtown how much respect the commissioners have for you, Pam, and the job that you've done.
I appreciate the work you've done, even though I'm not always on time for our meetings. But I also appreciate your personal patience, and then just the view of what our mission is and supporting that, because there's a lot of finance people that would come in and just want to switch everything to like, well, this isn't how the last system I did work. This is a much different system, because there's a healthcare generally, when you talk about hospitals, is a not-for-profit industry that's really a for-profit industry masking itself as a not-for-profit. And I'm not pointing to any entity in particular, but you went from a significant system to here, which is a significant system with a lot of different underpinnings to it. You adapted very well, and I just want to tell you how much I appreciate you and the work you've done. And I'm curious if you're going to retreat back to like Fort Wayne or anything like that. Okay.
Yeah, well, so a couple things. I think I've referenced my time here or my career, I guess, as a whole, as Goldilocks, right? I started out in public accounting, and for first 8 years of my career, after 8 tax seasons, I said, I don't want to work 60, 70 hours a week anymore. So I went to work for the local hospital, which was a client of the accounting firm and was for-profit. And I worked for them almost for a better part of 15 years, and it never really sat right with me, right, on what is our mission here. I mean, they would speak the speak, but they wouldn't walk the talk. And so then I went to Catholic healthcare, which, again, a lot of hearts in the right place, but still didn't feel quite right, right? So it was like, you still have to make a profit to give raises and to buy capital equipment. I think that my rub, and this is a personal thing with Catholic healthcare, was their views on women's reproductive health, right? That was my only real complaint there. So, but again, this isn't quite right either. So like I said, I felt like Goldilocks. This system is too hard. This system is too soft. And maybe government is just right. And it really has been probably the best fit, I think, as far as people who have their hearts in the right place and want to put their minds to how to achieve what's best for the patient. On a personal level, some of you also know that my husband retired almost 2 years ago, so that's why I'm finally pulling the plug. We have a multinational family, and he's South American. So when we fly south for the winter, we really fly south, and I can't work remotely from there. So that is really the impetus for my decision.
God bless you. I think I speak for all of us here. We're all, I think, there's a couple folks who might be a little bit older, but we're all a bunch of middle-aged people that could probably appreciate warmer weather during the winter.
For sure. Yeah, so going back to your question, the lake north of Fort Wayne, where our children and grandchildren are, will be 6 months in the northern hemisphere, and then Lima, Peru will be 6 months in the southern.
Nice.
Yeah.
Nice.
So. All right, now I'm really going to turn it over to Scott.
Okay. All right, Scott, the grant award related items.
Yeah, all right. So we got one grant award, which is a renewal, $246,000 through Gilead Sciences. Any questions on that?
Any questions? All right. Hearing none. Is there a motion to receive and file item 5B, the grant award related item? So moved.
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye. Aye. Opposed? The ayes have it. All right. So which one of you is doing the October financials? By the way, the foreshadowing on all this has existed for the last 4 or 5 months.
Yeah.
At least. Don't.
You've noticed.
Oh, yeah. Oh, yeah. Yeah.
All right, so jumping.
Before I found out on the down low, I noticed, so.
Yeah.
So we've got October financials here. So the health system is largely in the same position that we've been in the last few months. Though in the month of October, things did improve slightly on the healthcare services side, but overall, unfavorable 67.4 million on an accrual basis and 18 million unfavorable on a cash basis. And looking at the drivers, those also remain the same in terms of unfavorability on the net patient service revenue side due to the lower than budgeted volumes and increases in charity care that we've seen, and then favorability on the capitation side due to the higher than budgeted county care membership. And then as you'll see later in the deck, we'll get into the county care financials, which are 98.9 million unfavorable to budget. Next slide. So on a combined basis here, we've got, so starting at the top, net patient service revenue, adjusted MPSR 195 million unfavorable, but adding in the favorability on the capitation side, 359 million. Total revenues are favorable to budget by just under 159 million. And then as we work down through the expenses, unfavorable to budget by 222 million, comprised of the medical claims expense unfavorability, and then partially offset by the favorability on the salaries and benefits line. On the next slide, the net income waterfall here, aiming to show you the favorable and unfavorable drivers. We've got the NPSR and the medical claims in red, which are the unfavorable drivers, and then capitation, salaries and benefits expense, and then purchase services and other, which have remained favorable drivers. In terms of the key volumes, both at Stroger and Provident, largely the same here, average daily census, ER visits and surgeries behind budget, but the one thing to note is the surgeries at Provident, that the unfavorability there has gotten a little better over the last 3 months as the GI procedures have picked back up. And then on the outpatient side, we have primary care visits that remain behind budget by 7.5, and specialty care that remains ahead of budget by just over 4%. So as far as payer mix goes, yeah, thank you. As far as payer mix goes, Medicaid at 51.6%, so 0.3% decline in Medicaid during the month of October, and uncompensated at 22.2%. On the revenue cycle side, so revenue cycle performance continues to strengthen. AR has largely recovered from the Change Healthcare cyber event that occurred almost 2 years ago. We still have some focus on the AR greater than 90 days. Though if you look closely at that slide, you'll see that the actual is pretty much at target, but still have a little bit more work to do in that area. However, cash collections are on target and projected to finish the year 9% better than last year. Next slide, the denials. Net final denials are below target for the 7th month in a row, as the team continues to address and chase the root causes and get the resubmit claims to ultimately bring the dollars in the door. The charitable and public program expenditures. So the projection here of just under 646 million is largely unchanged from what it's been the last few months. And the major drivers there being charity care and bad debt, or on this slide, the other uncompensated care. Our savings initiatives, on the next slide, sorry. Yeah, savings initiatives continue across staffing, and contract management. And as you can see here, that we're effectively at our goal for the year with 1 month left to go. And then last but not least, the county care income statement showing the operating loss of 9. But again, just highlighting the drivers that are similar to what they've been over the last few months. We're seeing a higher medical loss ratio than expected due to the high-cost drugs and the NICU cases. And then roughly a third of that operating loss is associated with the state risk adjustment conversations that continue. And with that, happy to answer any questions you might have.
Page 26, the waterfall report, income, net income.
Yes.
I'm making sure I understand it. So everything we see here is revenue only that's based on this page?
No, there's revenues and expenses here.
Okay, great. So my question is, and I don't know why I never asked this question before, but when I see salary and benefits as a positive, and I think that is 103, he's in 1,000, so that'd be 103 million, right?
These are variances to budget. So if it's green, it's a positive variance. We're either over budget or under budget, depending on whether it's a revenue or expense, right? And then red variances are bad.
Okay, thank you, because that's actually helpful. Where would the use of the agencies fall on this chart?
Mm-hmm. That's in the green bar, purchase services and other.
Which one?
Just left of the medical claims, the large red bar on the right-hand side.
Okay.
Step over to the right. The green bar to the left of that big red bar.
Yeah.
Right there.
So that number is representing what exactly?
So it's the positive variance to budget. So for example, and actually, if you go back a slide, you can see that line, right? Purchase services and other, 140, there, we budgeted, I'm sorry, I have to look on it here. You have it?
Yeah, we budgeted 763 and we're at 617. So we're under budget or favorable to budget by 146
million. And so that's what shows on the waterfall slide is as a green that we are 146 million better than budget or under our budget in this case.
So we budgeted for the use of funds toward the agencies.
Correct. And we have used less than we budgeted, yes, because of the initiatives that we've been working on.
Okay, and again, this is in reference to the budget, which is the operative word here.
Yes.
Thank you.
And so that green bar, though, 146 million, to Chair Ryder's point, right? The 146 million largely offsets that first red bar, that negative 224 million, that we're under budget on net patient service revenue. So on the hospital and clinic side, our revenues are under budget, but we're offsetting that in the expense side with savings from using less agency.
So that way, when you expect on the P&L expenses over revenue, they're offsetting.
Exactly.
That's a good question. So Pam, what does that do to I assume there's an admin rate?
But hey, by the way, Ralph, just before we leave this point, every other year we've transferred money out of employee lines and other lines where we had vacancies or where we didn't use funds, and we've done an internal transfer to agency because we overspent. We were going to overspend on agency. This is the first time where agencies help fund something else in the budget.
Correct. Or offset. Correct.
Offset.
Yeah.
So it's not technically a transfer.
So my question is about the administration portion of the revenue. So how does that get impacted by less revenue? To that budget? Because this is operations drives the revenue. So the administration portion is affected. So I understand the net outcome is close to being even,
Right.
but then there's still a hit to the administration side. So I'm wondering how we.
Are you talking about on the, so if there's less revenue, Curtis should need less people to collect that revenue? Is that what you mean by administrative?
No, I'm not making that suggestion, but I am, yeah, Curtis or Wynn or.
Yeah, across
support.
the organization. So, I mean, in theory, certain things flex with volume and certain things do not, right? And in theory, supplies should flex according to volume and salaries, people should flex to volume. However, if you have, example, at Providence, a low census, and you need to cover one patient, you need 3 nurses, right? If there are 8-hour shifts, you need 3 nurses. If there's one patient, or if the ratio is 5-to-1 or 4-to-1 or 6-to-1, right? You still need those at least 3 nurses.
Agreed.
So that's a sunk cost. So
Agree.
so it's
So I'm speaking more of like HR staff or legal
So
staff.
finance.
Because that doesn't necessarily fluctuate.
No, finance, right? We do not
Finance,
fluctuate according to volume. HR does not fluctuate according
That's
to
right.
volume. Theoretically, we should, but we do not.
Well, and I would point out part of the reason why on some of these administrative positions, we don't, is that, like right now in HR, we've been dealing with a backlog, not only with the transition of onboarding people through the agency. Those agency positions, to look at it another way, many of them were unaccounted for vacancies in the budget. We didn't have PIDs for them, but we had grown the system. So it's like one area, because we've been so backlogged on hiring generally, either because of agency or not filling vacancies.
Sure.
That, like, it'll be in theory, like Pam said, in theory, your human resources department would fluctuate with the amount of business you're doing because of your hiring or your separations. But we still are trying to catch up to the
And in
base amount.
And finance too, right? I mean, we have the same amount of work to do regardless of volume. The processes that have to be done every month to close the books, right? Whether the revenue is 2 million or 200 million, the steps that have to be taken, the stuff that has to be done is the same. So some departments do flex, some departments don't. A lot of the support departments like IT, HR, finance typically do not.
And then on the service delivery side, we've been able to operate safely through our use of in-house positions and agency to deliver services, but it's never been staffed to where we want it to be, or where we would feel like we're in a good spot. So that's another place. It's also why, some of the national headwinds on healthcare, it's like it's always going to be fun around here, because as soon as we get it figured out, we don't get to settle in and get on a normal track to some other insanity. Yeah.
I guess the reason why I asked the question, because when I look at it, and this is somewhat obvious, but when I look at it, this is the way in which we are using the monies, right? You're recording it as it is being done. So that's not my question. My question is, when we start looking at from the standpoint of running an operation that is actually being able to produce the revenue that's needed. That's where my question is really starting to drive to, because when I look at this, and again, this is not saying you're doing this, but it gives almost an optical illusion of what's really happening. And that's my concern, which you're a finance person. I think you understand exactly what I'm saying. And that's where the concern is, not necessarily if we don't put all of this together to understand how do we get this ship right. We're doing a great job, but we still have yet a large job in front of us. And I'm disappointed that you're retiring.
Well, I think we all agree on that. I think one thing that when now we're into a whole new budget year now, right? We're 2 weeks into it. The last year was a transition year because a lot of things, the agency transition happened during the year, and we budgeted for it, but it was still ramping up. So there's that piece. There's also, some of the anxiety around what was going to happen with the Medicaid payments. So there's a lot, and then the immigration raids, which also disrupted people coming into the system. So it's not going to be the year that you're going to want to benchmark the performance against, because you had a lot of unexpected events happening all at the same time, and you had to lean into and lead through it. So
Yeah.
This year though is we know what we're up against, because it's going to be all the same bullshit that we had last year, but now we've had time to sort of figure out what the strategy, the position is in it.
Yeah, and I mean, the other piece is the shift in Medicaid coverage already with redetermination starting this last year. I mean, we've gone, in the last year and a half or so, it's gone from 13% uninsured to now 22% uninsured. That's a huge.
I was gonna say that.
So, and the other piece.
Market force.
Sorry.
No, go ahead.
The other piece was HBIA. That was 111 million that we were heading for in terms of lost revenues. I think, Pam, we were trying to close somewhere between 150 and 175 $175 million gap.
200.
Yeah.
200 on the provider side.
Because it ended at the end of June, and there was underlap between there and when our year started 2 weeks ago.
Right.
So you lost 4 months or 3 months of revenue there.
Right.
And I think on the provider side, just rough math on the provider side, it looks like we would be about net positive 30 million, right? Because we separate out the plan and the provider, right? The provider side, all the, the belt tightening, the process work, all of that we've been doing this year, I think has really tried to, took us from a 200 million loss to slightly positive, again, in the provider side, right? I know on balance we're not.
Yeah, I mean, with one month to go here, right, we're ending the year basically 80 million in the hole, probably slightly worse, for November, just, to tee that up, although we just started closing the year-end books. But the exercise we did at mid-year was to get that 81 million negative to zero, right? We were trying to cut costs to come into break even, because that's really from accounting perspective, all we have to do here is break even. Revenues have to equal expenses. They don't want us in a deficit so we have to do a mid-year plan. If we're projecting a deficit, we have to do a mid-year plan to try to bring that back in line, which is what we did. And you can see as Eric said, we were projecting a 200 million, had we done nothing at mid-year, we were projecting this number at the end of the year would be 200 million negative. And we've cut it in half, which is really, really good progress, right? But the budget is built on assumptions we know at that point in time, right? So again, it was built on what we knew as of June of last year, right? So even though we just kicked off the new budget, it's already outdated because we still don't know some of these Medicaid impacts, right? We did not budget for dish cuts. We were under the assumption that they would get pushed out again. They were only pushed out to the end of January. So if that happens, we know it's a $12 million a month hit to us, that we did not budget. So we'll have $12 million a month less revenue coming in, and we'll be having to do a plan, right, to try to, again, close that gap.
Go ahead, Ralph.
I was gonna say, the state didn't predict 19 months ago when it passed its budget that there wouldn't be HVI coverage for immigrant patients. So our budget came months after that, assuming that was gonna be the case, and then federal changes happened in November of a year ago.
And this is where if I was having a meeting with my staff back at the CFL, I would say, do you know why this is important? And they'd say to me, Bob, I'm tired of the Socratic method, and I would tell them that when safety net, when the private safety net hospitals are under threat, some of them close, or when the big not-for-profits and the university-backed systems cut services to adjust. Stroger and U of I Hospital are going to persist because they have to. So making adjustments to keep ourselves at that break-even point or better is critical. So you keep pushing that rock up the hill for the day that you need help. And that's why the further we can push that off, the further we can go, because we have to persist. All right.
That's it for us.
Any other questions? I gotta tell you, I really like this. I like this committee. I like the people on it too. This is fun.
And we like your fashion.
All right. Since we took our informational report earlier, we have exhausted the agenda. We're adjourned. Thank you.